Hello everyone and welcome to Longevity Article Review number 5. My name is Jordan Marsh and I'm happy to share this article with you. This one's a really cool one and I'm excited to get into it. Of course, we'll start with bird nerd time. I just want to tell you a bird that I really like. These are Atlantic puffins. Atlantic puffins are known for having kind of a season in the summer, around April to about August, of being up in Maine. So definitely one of my bucket list trips that I want to take before I die is to go see these puffins either in Maine or in Iceland. What's cool about them is that they're on land for that amount of time, from about April to August. But when they migrate away, they migrate and basically live in the sea. So they're on top of the water for 8 months at a time, diving up to like 200 feet, I think, I think it was 200 feet that I saw. So these are really cool birds. They're also just beautiful. They kind of look like penguins, obviously. Look these up, and it definitely makes a cool trip either to Maine or Iceland. So give that a shot. All right, so this study describes some really interesting things. And I wanted to first show you this quote that said, "The majority of previous studies have not clearly assessed the independent prognostic power of exercise capacity relative to other clinical variables and information from exercise testing." So what does that mean? Basically, we're trying to say, does the exercise capacity of somebody give us an idea of how much longer they will live or how long they might live? And how does that compare to other clinical variables like high blood pressure or diabetes or obesity or things like that? So this study actually did what I thought was a pretty good job of teasing that out and showing us that we can find a lot of good information in just our exercise capacity, our VO2 max. And we're going to talk about VO2 max in terms of METs today, and METs are metabolic equivalents, and I'll get into that a little bit more later. So there's two subjects in this study, subjects with cardiovascular disease and then normal subjects. Of course, cardiovascular disease, they had to have a history of at least one of these things: coronary artery disease, history of heart attack or myocardial infarction, peripheral vascular disease, and any of those other things. But then also we're just looking at normal subjects that are somewhat age matched, and actually they were age matched. So we're trying to look at two groups of people, and specifically men again. So we'll have to talk about that as a limitation again, but we're looking at these two groups and trying to tease out what their exercise capacity tells us about them. All right. So before we do that, I wanted to show you exactly how they measured this VO2 max for this group of people. So the average age of both groups was around 60 years old, and I have a graph later that I think will show us that. But we couldn't necessarily do an actual VO2 max test on these individuals. What was special or unique about this is that we were basically just taking anybody who had been referred for exercise testing in a clinical way. Okay, so maybe not, these guys probably couldn't handle a precise VO2 max test. Maybe the purpose of their exercise testing was not to actually measure their VO2 max. It was actually just to measure how well their heart responded to exercise. And so we needed to approximate VO2 max, which will be a limitation of the study, but this was kind of like an example of how they might have done that. So this shows us that we can take the speed of the treadmill that they were on, we can take the incline of the treadmill that they were on, and then use that in a way to approximate what their VO2 max might be, okay? And so that's exactly what they did. This is how they measured their VO2 max, but then they converted all of this into METs, okay? So METs, I'll get to this next, I'm gonna do it here. So this is an example of how they might have done that. So they calculate VO2 max with the speed and incline of the treadmill, and then they convert to METs by dividing by 3.5. And what is special about 3.5, or the number 3.5? Well, that number approximates one metabolic equivalent, okay? So I'm going to say one metabolic equivalent equals 3.5 milliliters per kilogram minute. I'm sitting on this chair. If I'm just sitting on this chair and at rest, for the average adult, one MET, or metabolic equivalent, is about 3.5. That's what I'm doing right now. When I'm just sitting here doing nothing, I am just relaxing. I'm using 3.5 milliliters of oxygen per kilogram of my body weight for every minute that I just sit here and do nothing. So when we convert to MET, when we're talking about METs, all that a MET is just we're using that 3.5 number as a baseline for what we do at rest, and we convert it to how, like when we're exercising at our maximum capacity, we're saying how many more METs are we using. So rather than, so this individual, let's say this individual who had a VO2 of 48.3, when you divide that number by 3.5, you see that their METs are about 13.8. And that means that they're using about 13.8 times more energy than they would if they were just sitting at rest quietly and comfortably, okay? And so that's important to know because we didn't actually get their actual VO2 max. We just approximated their VO2 max, and then we use METs to say how much they were able to exercise above their baseline, okay? So that's going to be important for later. Remember that for later. Here is a table describing the demographic characteristics of our groups. And I did want to just highlight here, all subjects' age was around 60, plus or minus 11. So a pretty fair range. Of normal subjects, look at how many subjects we had. So around 2,500 normal subjects and around 3,700 subjects with cardiovascular disease. And they're all around the same age. So normal subjects were 55.5 plus or minus 11.8, and cardio disease 61.5 plus or minus 10. Okay, so important to notice that, you know, again, these are people that are being referred for clinical exercise testing, and we're just going to use what we get from their clinical exercise to approximate their VO2 max, and then see exactly what their METs are. Those METs give us a good idea of how much we're able to use their exercise capacity as a prognostic tool. All right. So here are the results. I think this is just beautiful. It teases it out perfectly. Okay. So let's start up on the top left with, you know, normal subjects. So these are the normal subjects in the group. These are those that don't have cardiovascular disease. And this is a survival curve, okay? So that's right down here, survival curves. On the x-axis is years of follow-up. So basically we just did this test, and then we followed these people and said, did they die by this period of time or not? And, you know, again, here is kind of the percentage surviving. So what percentage of these people actually survived over the time frame that we examined them in this study? So in the top left, we're looking at normal subjects. As you can see, if you were able in your exercise test to be able to eclipse at least 8 METs, or 8 times the amount of energy you would have used just at rest, then you had a much stronger likelihood of surviving a 14-year period. I should say that not every one of these subjects was examined on day one, you know, so they started in 1987, and then by July 2000 they just cut off the study and said, what are the results that we have? So the average follow-up was around 6 years, but for some they were able to get information on 14, 10 years, 11 years, 14 years out. Okay, so you can see that your chance of surviving is much greater with at least 8 METs of exercise. Of course, with around 5 to 8 METs, your chance of surviving is a little bit less. And then at less than 5 METs, again, your chance of surviving is even less. So, those that could exercise less than 5 METs had about a 50% chance of living longer than 14 years after the study. But those that could do more than 8 METs had a almost 80% chance of living longer than 14 years. And remember, if the average age is around 60, that means that these individuals lasted pretty long afterwards. So that's for normal subjects. Here we see subjects with cardiovascular disease, and we see kind of the same relationship, albeit a little bit, obviously still a little, it doesn't surprise me that they still had maybe higher mortality because of their history with cardiovascular disease. But still, the relationship is still the same, that if you can exercise more than 8 METs, much higher chance of living longer, and of course, if you can exercise less than 8 METs, then your chances of survival were actually much less. Okay? So I think that's really powerful. I'm not going to dive too much into the ones on the bottom, B and D. Just those were, the predicted amount of exercise that they could do relative to what, their age group was and relative to what their cardiovascular disease status was. And so still shows kind of the same idea that, the more exercise you can do, or the more that you can do that we predicted you could do, you turn out better. And the less that you could do based on what we predicted you could do, the worse you would turn out. Okay? So you might ask yourself, okay, wait, what if there's something else that's explaining this relationship? What if it's because of other factors like heart disease, like, diabetes, like obesity, like a history of smoking, something like that? I think the authors anticipated this, and they actually showed in this table some really fascinating things. Okay? So let's start with just breaking this down. I'm going to put a line right here so you can kind of see that we are separating out normal subjects or subjects with cardiovascular disease. As you can see, the normal subjects their peak exercise capacity is up here. And also for subjects with cardiovascular disease, the peak exercise capacity is here. So that's one variable that we are looking at, but there's many other variables we're looking at. So for normal subjects, as you can see here, pack years of smoking right there, history of hypertension, diabetes, total cholesterol, left ventricular hypertrophy, which is just a chamber in our heart that has grown big. Is that a prognostic indicator? And other things. All of these other things are things we are seeing if they had good prognostic value too. Okay? For cardiovascular disease, it was a little bit longer, but very similar. History of congestive heart failure, history of MI, pack years of smoking, and on and on and on and on. Okay? Okay, what is a hazard ratio? A hazard ratio is a way of just comparing two groups and their relative risk of death, especially in this instance, their relative risk of death. So if we have Group A here and Group B here, and we're saying, let's say the risk of death in Group A is 0.5, and the risk of death in Group B is also 0.5. That means that there's no difference in their hazard risk. That means that their hazard ratio is 1. Let's say the hazard ratio in Group A is 0.5, and the hazard ratio in Group B is 1. That means our hazard ratio is 0.5, meaning that the risk of death in Group A is much less than the risk of death in Group B. And of course, you could do the same thing in the reverse, and my hazard ratio is 2, or my likelihood of passing away is much greater in Group A than Group B. And so it's really important for you to understand that when you're looking at these numbers. You're saying, specifically, let's start with the peak exercise capacity in normal subjects. So the hazard ratio there is 0.84, and there's a confidence interval of 0.79 to 0.89, which means we are 95% confident that the actual hazard ratio lies somewhere between 0.79 and 0.89, which means we're really fairly confident that the hazard ratio is not 1. And if it's not 1, that means that there is a difference between the two groups, which means our p-value is much, much less than 0.05. And so here, the way that you can interpret this is saying, for every 1 MET increase in our peak exercise capacity, for these normal subjects, their likelihood of death decreased by 16%, or 1 minus 0.84. That's about 16%. And you could say the same thing about those with cardiovascular disease. You could say with each 1 MET increase in their peak exercise capacity, their risk of death decreased by at least 9%. And again, we're fairly confident that that's not 1, so we know that it's significant. There's a good chance that that's actually true. And so, as you could see, they did this for a bunch of different variables. So you can see why they have all these different variables that they're looking for the hazard ratio and seeing if those also explain why some of these subjects might either pass away or not pass away within the follow-up period of the study. But for both groups, peak exercise capacity was a very good way of determining what their prognostic likelihood was. So pack years of smoking was also significant for both groups. For the cardiovascular disease group, the history of congestive heart failure, myocardial infarction also explained why they might have passed away earlier. However, for both groups, we know that peak exercise capacity was an excellent way to determine what their likelihood of death was. Okay? So, really cool study. It's actually elegant and beautiful, and just seeing those exercise curves made my soul just sing to the birds that I love. So here's 3 good things from this study. Exercise capacity is a strong prognostic factor even in men with cardiovascular disease, not just those without. So one thing that they said many times was that most studies prior to this one had shown that peak exercise capacity was a great prognostic factor in younger and more healthy individuals, and there was no real solid evidence that it was good for even those that were maybe older and not so healthy either. So we know that exercise capacity is also a great way to determine that even in older folks and those that also have comorbid conditions. It's a nice incremental goal. So if you average, remember I told you that the decrease in the risk of death was 16% for normal subjects and 9% for those with cardiovascular disease. If you average those twos out, then you get a 12% improvement in survival for every 1 MET increase, which is a really awesome incremental goal. You can say, hey, my goal over the next month is to increase my METs or increase my exercise capacity by at least 1, so that I have a 12% improvement in my ability to survive, which is awesome. And then I loved this quote from what they said. In all subgroups defined according to risk factors, the risk of death from any cause in subjects whose exercise capacity was less than 5 METs was roughly double that of subjects whose exercise capacity was more than 8 METs. So we have a nice incremental goal, but maybe we have a nice overall goal, especially in those that might be somewhat elderly. If we can increase our exercise capacity to at least 8 METs or more, then we are giving ourselves a much higher chance of survival. 3 things to consider, as always. The findings are only applicable to men. They only studied men, and they studied a lot of men. So, again, I don't know exactly how this relates to women, and I'm sure there might be some changes as it relates to them, but still could be somewhat applicable to them. They only had information on death from any cause. They did not know the specific causes of death. So, of course, some of these, there might be some noise in this data from maybe some automobile accidents or other things that aren't necessarily indicative of, the natural course of aging. And then the exercise capacity data was estimated on the speed and incline of the treadmill. And so it would be better if we had actual solid hardcore evidence of their VO2 max. We did a true VO2 max test on all these individuals, but we approximated it. And so that's something to consider as a potential limitation of the study. So, all right. Thank you so much. I hope you're enjoying these as much as I am, and we'll see you on the next one.